what happens when we break a bone makes a lot of sense. Now, this lecture is going to go through lots of words, complicated concepts, but basically, we're going to break that bone, we're going to bridge it with some cartilage, and then we're going to fill bone back in. That's what happens. We break it into phases to make it more understandable. Reactive, we get a hematoma. Look at that prefix heme. We've got sort of a blood clot in there. And this blood is going to leak into the tissues around the site of the injury. We get some edema, some swelling, some pain, and that's good. Some of the bone cells are going to die, which isn't good, and that's because of the torn blood vessels that normally bring oxygen, glucose, other things are not doing their job because they've been destroyed. And so the osteocytes in those are the living bone cells, are dying. Damaged cells release histamines and cytokines, and that occurs all over the body. Whenever we have an injury, we're going to get histamines and cytokines. And they're going to attract phagocytes, which are white blood cells that remove dead and damaged tissue. Those are the cleanup crew. I mentioned edema. Bone repair, and on to the reparative phase. That's when we're going to make this fibrocartilage, and that's going to bridge the gap, and eventually it's going to be filled in with bone. Blood vessels are going to infiltrate that hematoma. Remember, hematoma is just a big blood clot, and in this way phagocytes are going to pour into the area and start to clean up the dead bone cells and cartilage so that repair can take place. The outer covering of the bone, think of peri means around or outer. Periosteum is going to produce those collagen fibers that help to keep bone elastic. And the collagen also forms kind of a framework, for the bone to be deposited in later. Chondrocytes, there's that root word chondro, meaning cartilage. So together we get this, it's almost like a gel at first, like the ends of a chicken bone, that white material. It's fibrocartilage, but it's soft, and it's just going to bridge the two broken ends in the first 3 weeks after the break. There's a second part of the reparative phase, and that's when these osteoprogenitor cells are going to come from around the injury site and become osteoblasts. And osteoblasts are the good guys. Okay, they blast together a new bone. They're going to form first the spongy tuberculae, because we'll begin with the spongy bone and work our way into producing compact bone. The purpose of the tuberculae at this phase is to join the dead and the living parts of the original bone. So if you take a look at the diagram, I know it might look kind of funky there, but we're starting to see a piecing together of damaged cells that are still useful, at least useful for a while, with the new growth. The callus, we call it a callus. Okay, so the callus can be a soft fibrocartilage callus, and over time there is a deposition of calcium and phosphorus and other minerals, and we're going to gradually convert that cartilage callus to a bony callus, and now we got something that's fairly stable for about 3 to 4 months. Now we're still not there, so the bone is still somewhat vulnerable to re-injury, and that's why sometimes a cast or splint is left on there even though the patient is itching and uncomfortable and wants that thing off. But the bony callus is still not true compact bone. Finally, the last stage, we've gotten there. We're looking at, it depends on the break and the extent, but 5, 6 months down the road, sometimes 8 months, a year, we finally have true bone remodeling, and that's where the osteoclasts are going to finish the job by absorbing particles that were not completed by the phagocytes. And now we have those osteons. Do you remember the ring-like growths of bone, compact bone? And it's going to replace spongy bone, at least on the periphery, and then the internal will still be some trabeculae of the spongy bone. This diagram, the upper one's a little fancier than we need. We don't need to know about mononuclear cells and pre-osteoblasts. But I want you to get the idea that it takes several months for this bone remodeling, because calcium and phosphorus are not in large supply, and so they're deposited slowly in the injury site. And we have to weave those mineral salts in with collagen so that bone is both has high tensile strength, but is also very dense. As we age, our osteoblasts are not as active, and so this process is going to take a lot longer. If the process occurs properly, often there's only a little thickened area in the periosteum that is evidence of former breakage. Again, here's this diagram. It is kind of nice because it shows the osteoclast absorbing bone, osteoblast depositing bone. So it's good to get those two types of bone cells straight. Mechanical stress. Anytime we put stress on bone, primarily from muscles, okay, that's the main way, then we're going to stimulate the osteoblast to deposit collagen and mineral salts. Weight-bearing activities. And this is why, if you carry a load on one shoulder, your bones will actually thicken on that one side. And that's another reason why we get people out of bed when they're in the hospital as much as possible, because we can lose up to 1% of our bone mass in 1 week just laying around in bed. All right, and so there's all sorts of devices to keep people moving. In some cases, bone reabsorption, and that's the activity of the osteoclasts. Okay, they're reabsorbing bone, which is usually not a good thing. If that outpaces the deposition in middle age, then we have something called osteoporosis. That it's more common for women, but partly because of menopause. And men are just larger; they have bigger bone reserves, but that's not always true. Some men are very thin, and so they're susceptible as well. Demineralization. Okay, so this is the story I've just finished talking about. As we get demineralization, the loss of calcium and other mineral salts, then the bone mass is reduced, and then bone brittleness. So we have people fracturing bones when they fall down. After age 30, so this is important when you're young to build up a nice, healthy reservoir of bone, staying nice and active. And then we start to lose it around 45. I mentioned women and menopause. It's due to estrogen. It's one of the problems with being thin. I mean, we often think of being thin as the way to be. But in terms of bone, all that body mass pulling on the bones does sometimes help maintain bone mass. Women lose about 8%. Well, they don't have to, but women who are inactive and are not taking any kind of hormone replacement therapy will lose up to 8% after age 45. Men lose about 3% every 10 years after age 60. But again, that's not true for all men. It depends a lot on their activity and also their hormone levels as well. I mentioned brittleness caused a reduction of, it's a reduction of collagen, but often due to reduced protein synthesis, and that's occurring in the cells with ribosomes and amino acids. So fewer collagen fibers means the bones lose that tensile strength, and so they're easily deformed. And that's when we start to see people shortening, their height diminishes, teeth start to fall out as the sulcus of the tooth is deformed, and pain and reduced collagen. Not a good story here. A bone scan is when we use an IV injection of a radioactive tracer, and it's usually absorbed by living tissues that have a lot of activity, and which means usually a large blood supply. We use a gamma camera or some other scanning device to measure those emissions. Now, on a typical healthy bone, we expect to see a grayish image because bone is fairly steady in its emission of these of radioactivity. But if we see dark areas, we call these hot spots, then that indicates high rates of cellular metabolism. Now, that could be a good thing. We just have increased blood flow. Or maybe we have some healing of a fracture going on, or some other tissues nearby are pouring blood into the area. So it can be good, but then cancer, osteosarcomas, maybe dark area may be indicative of that. Light areas, cold spots, we call them cold because there's a reduced blood flow, reduced metabolic basal rate there. Many causes for this. Usually light areas are not a good thing unless we're looking at the interior of a bone where we expect it to be less dense. Degenerative bone disease, decalcified bone, so we think of what we've just been talking about, osteoporosis. Bone fractures, infections, rheumatoid arthritis, and other types of arthritis as well may cause a thinning of the bone. Rickets, we don't see this as much in our modern world because vitamin D is, we find that many products fortified with vitamin D. But some people have an inability to absorb vitamin D, or they live in very poor conditions, not drinking any milk, they're drinking Coca-Cola and eating white bread. It's also called osteomalacia. The IA is not a, it's a, oh no, a Malaysia, sorry. That's in adults, and that's pretty rare. Osteoclasts are not able to fully ossify, and that means they're not able to deposit enough calcium and phosphorus at the epiphyseal plates, so the cartilage never becomes calcified, and so it's very bendable. Treatment, the simplest treatment is vitamin D. And sunlight, because sunlight, when it's exposed or it penetrates the surface blood vessels, it will convert some of the cholesterol, the lipids in our bloodstream into vitamin D. And that's why we tend, young kids, we tend not to worry as much about sun exposure. We don't, sometimes we hold back on the sunscreens because that, especially ultraviolet radiation striking the skin, can help form some vitamin D. Orthodontics. This is an interesting process because it involves bone, right? It's not just about teeth. It's done to establish proper occlusion in the upper and lower, the mandible and the maxilla being the upper, and it's going to cause increased osteoblast activity on the one end. So let's look at this. Teeth are going to be moved according to pressure, and so the sulcus or the tooth socket is going to kind of be reformed. On the leading edge, osteoclasts are going to remove some bone so that the tooth can shift, and then behind it, osteoblasts are going to deposit bone. And this works best when you are young, because what happens when you're young? Okay, the bone fills in nicely, but when someone in their 40s has braces, often there's a lot of bone recession because the osteoblasts are not as active. And this is another reason, if you lose a tooth, or you have a grandfather or someone that loses a tooth, very important to put an implant in there, and not just some kind of fake denture or a bridge, because every time you chew, the root of your tooth is stimulating bone growth. And if you lose a tooth, there's no stimulation, and so the bone's going to retreat. And gradually, well, do you remember that woman in that earlier slide? Pretty soon, your jaw starts to shrink, and it's a cascade of problems. So implants, they're expensive, but they are worth it. Believe it or not, one day you will grow old, and you got to be ready. All right, thanks for listening.